We're back with another PCBH corner. And we have a topic. A topic that we may or may not answer. Just kidding. We're going to answer. The topic is, how long should your BHC visits be in primary care behavioral health? And so the answer is 28 to 30 minutes.
Yeah.
For the short answer. And for those of you who want to hear the actual answer and the nuanced answer, I would definitely suggest to continue listening.
Yeah, and I think we'll talk a lot about, I think, the context that shapes the answer and where it comes from and all these different things. I think the one thing that my mind says to start out with is that you do such a great job explaining this, and you compare it a lot of times to us going to get a massage. So Bridget and I, we do a lot of self-care. One of the things that we do usually when we're home on Saturdays is we'll always go and we'll get a massage. And we'll talk about it regularly. We're joking around. It's like, oh, we got shortchanged a little bit, right? Like it was like, maybe it was a 60-minute massage, but it's like, hey, we were only in there for 50 minutes or something, you know? And it's interesting. That's the way a lot of the mental health work is done in the sense of, how a visit is ending, similar to a massage, is like how much time has transpired in that visit, which then promotes this kind of almost rigid way of looking at this, is that we need to do 50-minute visits, or even, as we're going to say, 20 to 30 minutes should be the number of minutes for the visit. That's almost kind of like, say we did that, we said it was 30 minutes for a PCBH visit. I still don't know if I would agree with that just indiscriminately, because it's like, well, I don't know. The visit might only need to be 10 minutes. The visit might need to be 45 minutes. So while we'll talk about the average being 20, 30 minutes, I think the one thing that comes up with this is that also recognizing this is something we hold almost rigidly to as a mental health field, that before we enter the room, we know how long that visit's supposed to go and supposed to be. And honestly, I think that just gets us into a really bad place when we're trying to work in primary care. Maybe in a traditional mental health setting and different things, not speaking of that. But if we go into that visit with an assumption, this is how long that visit's going to be, we're going to be in not a great place.
Yeah, and I did say 28 to 30 minutes.
Oh, you did say 28, yes.
Yeah, because I think the 20-minute thing is, I just don't think that's the most common scenario. But anyways, back to all the things that you pointed out. I think that's so right, because say we said 28 to 30 minutes. What if the visit was done when the visit was done, we had a good plan, and we talked about that in other corners, that how do we know the visit's done? It's when you and the patient feel good about the plan that you have.
There's a moment that happened.
And so if that's 16 minutes, like you just said, and then we go 28 minutes, then that's wrong. And if we went 45 minutes, when what we could have got it done in 28, 29, or 30 minutes, and it's like, well, then that was too long. But if the context made sense for it to be 42-minute visit, and then you stopped at 28, and because you watched one of our PCBH corners and said, hey, well, Doctors Beachy and Bauman said that the visit should be 28 to 30 minutes, and I went, so I think it needed to go longer. We are on the verge of a really good plan, but I stopped it and I said, okay, your BHC visit is now done.
It makes me think about what Jeff, when we had these conversations with, because a lot of times when you do see articles, and it's even like a core component, and I think even in our core competencies that we use with our trainees, it's kind of like using appropriate time, like with the majority of visits being around this point. It wasn't supposed to be prescriptive, though. It was supposed to be descriptive.
Yep.
And it's the same thing with the number of visits per patient or interaction. Like usually it's 4 to 6. It wasn't supposed to be prescriptive, though. It was supposed to be descriptive. And this is a big thing that's coming up with it, that we're almost, from the beginning, we're forgetting why we're saying it's descriptive versus like, if you go, like you said, if a visit goes longer than 28 minutes or 30 minutes, it's like 45, like something was wrong. It's like, I don't know. And I often think about how that goes back to a primary care mindset too. If you go to a PCP, while they are scheduled for maybe 15, 20-minute visits, there's times that it might be, I tell this story all the time about going to see my PCP, and the visit was 5 minutes because we got what we needed done. The moment happened, everything was good. And if a PCP has a 15 to 20-minute visit, but someone's coming in for chest pain or heart. They don't wrap that visit up at 15, 20 minutes without fully assessing what's going on with that human. So it's also adopting a PC mindset.
Right. I was just thinking about, about what you're saying with a primary care mindset. And when Dave and I were talking about this topic, should have recorded that yesterday. It was really good.
I know, it was actually really good. Yeah. What were we coming home from golf or something like that? We were talking about?
We were coming home from golf. See, our minds were nice and free. Mm-hmm. The truth of the matter is, if you're a BHC and you're seeing anywhere between 8 and 12 patients on the regular, maybe you're averaging 9 visits per day, and you're answering the vast majority of warm handoffs. So there's not very many handoffs being missed. In our world, we would say like no handoffs being missed, but we understand there's different contexts,
Grace, love, and compassion,
different situations. Yeah. But if you're getting handoffs and you are available to your PCPs, you and your teammates aren't missing them. You're seeing about 9 patients a day. It doesn't really matter how long your visits are per se. I feel like that clip could be absolutely taken out of context.
Yeah, don't cut that clip right there. It's like, oh, it doesn't matter. Beachy Bauman said it doesn't matter how long your visits are.
Yeah, you have to take this whole thing into context. But the truth of the matter is the only reason why the visits are scheduled shorter and tend to go shorter are to be able to make sure that you're seeing a wide reach into the population and that you're accessible to your PCPs. So if you're accessible to your PCPs, and you're reaching a lot of patients, that's the goal. I mean, the 30-minute visits just helps us. It's one of the mediums to get there.
It's not the end.
And if you're finding yourself, you're missing a lot of warm handoffs, your productivity numbers are low, people say that they don't know where you are, I absolutely think it'd be very helpful to start logging those visits or tracking them.
Dare we say, and I don't know what minute we're into right now, but dare we
7 minutes? 7
minutes in, we're going to bring functional contextualism for the first point, right? Because the behavior, as you said, it's a behavior. The behavior of doing 20 to 30 minute visits is neutral until we place it in a context where there's a defined goal. And as you said, if you're seeing a lot of patients, you're getting a lot of handoffs, you're completing a lot of visits, PCPs feel like they can access you and stuff. Really, it's, I would say, whatever number of minutes that you're doing for that is right, because you're able to get handoffs, you're able to be accessible, you're able to see a lot of humans and complete a lot of visits. So regardless of what the number of minutes are, that's there. Now, we would just hypothesize that as far as probabilities go, if every single one of your visits 45 minutes and you can't get out of rooms or you can't make it to handoffs and stuff, we're going to guess all those things that we said define what success is for PCBH probably go down as far as a probability. So that's where, again,
it's a good way of saying it.
Descriptive though, not prescriptive, descriptive.
Yeah, and now I'm going to scar everybody with a return to stats.
Oh.
So normal curve, right? So, I'm not going to draw it today, but...
Oh man, we were going to ruin it. Yeah,
I know. But if you think about a normal curve and what's going down the middle line, that's what I think is like 28/30 minutes. And then I feel like you have just as many 23-minute visits as you do 35-minute visits. And then you have, 33-minute visits. And then so on and so forth. You have just as many 40-minute visits as you do 20-minute visits. And it just kind of goes out from there. And so the chances that I'm going to have a 10-minute visit is probably the same chances that I have a 50+ minute visit. It's very, very rare. And you kind of just start breaking it down. And it's funny because we do have access to the metrics and I've done self-monitoring over time.
And what have you seen?
Every time it's like 28.9 minutes as the average. But then when I look in there, I got me some 43-minute visits. I got some 48-minute visits. And then I got some 14-minute visits and some 18-minute visits. But the vast majority are 30 minutes.
Well, and
29 minutes.
And with us switching to Epic, we actually, I should reach out to our analytic team because we actually can pull that data about like specifically how many minutes each visit is.
Oh, we can?
We can. I haven't asked for that report just with everything that's going on. The one report that we can pull very easily is we can pull based on what billing code essentially that we're using. And what did we find? It was like 70 to 75% of the team's visits were under 38 minutes. And how we knew that is because the billing code
90832s.
90832s or the health and behavior codes that were. So we were able to see 70 to 75% of the visits all were under 38 minutes. Now, again, that's not saying that the visit was 38 minutes. It just said that we were using that billing code, so it was between 16 and 37 minutes. That is the vast, vast majority. So you talk about that bell curve, right? Like, boom, that's where like the standard deviations are really hit. And then, yeah, you have these things that trickle out to the ends of the different tails on each side. That some people might have 50 to 60-minute visits, same amount as having maybe 10-minute visits. You know, and I still remember seeing this for the first time. And I've told this story before, I think on other corners or whatever. But I still remember seeing for the first time Kirk doing a follow-up visit. It was a teenager, came in with their parent. They talked about the goals set at the previous thing. They had done them all. Both the parent and the patient were like, this is going great. And within 7 minutes of starting the visit, Kirk was like, okay, so it sounds like we can maybe check back in whenever you need to. And they were like, yeah. And we got up and we left. And there was such a moment that I had was like, whoa, 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 whoa. We got to keep talking. Like, we got to keep doing stuff. And the other thing that was really interesting to me, the patient and the parent thought it was normal.
Yeah. They felt good.
They felt good. They didn't think it was oh, I'm getting shortchanged right now. That this is something, yeah.
Like you said, when you went to see your PCP, and you all came up with your plan in 5 minutes, you didn't look down at the watch and say, I mean, do you even know what ours at our family medicine practice? Like, do you know how long those visits are? Is it 15 or 20?
Like an average, or
no, like when we scheduled the appointment.
Oh. I have no idea. That is a great point. I have no idea.
If we had to guess, it would probably be 15, maybe 20 minutes.
Yeah, I have no idea. That's a really good question.
Probably in 15-minute increments if we had to guess. But when you had your plan, you didn't say, okay, well, we've hit this 5-6 minute mark. That gives me 9 more minutes with your PCP.
You know what I loved about it, actually?
You were done.
I was done. I was like, oh, I can get back to work. Like, it was an amazing thing that it's like, not only was there a sense of like, we have something done, it was like, you're honoring my time. That's like, oh, we're good. Like, I can get back to work right now.
You had a resolution. You had a plan.
Yes.
That you felt good about and the PCP felt good about. And once you hit that point, that's when you George Costanza it. You're done.
Out.
You're out.
Let me ask you this. You know how we said about 70-75% of our visits fall into that 38 minutes or less category. What does our patient engagement stats tell us about provider perceived time spent in visits?
Well, I mean, they're satisfied with it because we're at the top of the top with the percentiles. Because the question just says, how satisfied are you with the time that your provider spent with you?
From the patient experience.
From the patient experience. And so it's in the 90-something percentile.
Crazy.
And so we don't know how long they think it's supposed to be, or if do they know it's about 30, that they're scheduled in like a 30-minute increment? I don't know.
That's a great question. I don't know either.
Because they are technically scheduled in a 30-minute increment.
Yeah.
But I don't really follow that. And when I'm doing the informed consent, normally during a handoff, I tend to go towards a little bit like, hey, we got about 15, 20 minutes together. And if we go a smidge longer, then that's fine. Whereas I'm going to set the stage that it could be quicker, because what if it could be quicker? And then if you're going to have them back for follow-up visits, every once in a while I have somebody say, well, how long are these visits? I say, well, they schedule about 30 minutes, but it's just like your doc where they schedule probably, in our system, it's 15 minutes. Schedule 15 minutes, but sometimes you get a plan a little bit sooner. Sometimes, it takes a little bit longer to get a plan. So in general, I say about 30 minutes, but give or take.
I love that perspective, because as you were talking about, my mind was going, it's like, man, we really don't talk about time that much in our visits.
It's
right?
a very small...
It's a very, very...
I'm assuming you've had that experience where folks had asked you about it?
Yeah, and again, it's rare. It is a really rare thing. And obviously in the form consent, as you said in our introduction, which, as always, make sure there's an introduction that follows 8 principles, and one of the 8 principles is the duration, right? The duration. Yeah. So to make sure...
That's a very good point.
That we should be including that in introduction. Outside of that, though, I never talk about time. I never talk about like, oh, we hit 30 minutes or we hit 20. Like, it is amazing about how much that has just been eradicated from my almost like the interaction that I have with the patient, that it's not based, or we don't talk about the time.
I'm actually going to talk out of two sides of my mouth right now.
Oh, we love those.
Because we said that, but my brain is now going to different scenarios. Like we mentioned a few as we've been going through here, different scenarios for why it might be a 10-minute visit versus a 50-minute visit. So a 50-minute visit. So what scenarios from your perspective tend to go a little bit on the shorter side as we describe it, and a little bit on the longer side as we would describe it, knowing that the only thing that makes it, whether it was the right amount of time, was if there was a good plan in place and everybody who needed access to a BHC within reason. Like if you miss a warm handoff because you unnecessarily went 50 minutes in a visit, that's not good.
Right.
But if you went 22 minutes in a visit, you got another warm handoff that took you 16 minutes, you got another warm handoff that was 24 minutes, and you got another scheduled visit that was 30, and somebody was like lost in there and there was a handoff missed, I would not necessarily jump to the conclusion you did something wrong. I might jump to the conclusion that you need more BHCs.
Which goes back to the why we always promote needing to track data, number of visits, and handoffs that you're completed, because you're 100% right. If a BHC is having a lot of visits, and we'll say a lot of visits is averaging over 9, and actual visits, right, like a meaningful clinical encounter that's billable, that we're seeing 9 to 11 patients a day, we're seeing 3 to 4, maybe 5 handoffs a day, like. At that point, if that BHC is missing handoffs, that's a reflection that there needs to be another BHC.
Right. So sorry, back to the original question. What situations and scenarios?
You know what's interesting, Bridge? Like my mind, like it doesn't understand the question, I think, at times. I think there might be some things at higher probability get to, like, this visit might be a little bit longer, this visit. But again, it's interesting. I was just talking to our trainees about this on two different things. One, time, and then based on follow-up. I never go into that room expecting a certain amount of minutes to occur within that visit, nor am I ever expecting I know how often this person's going to need to follow up. Like, that is based on the moment. So I would say, the truth of the matter is, I'll be vulnerable here, the ones that go longer is because I didn't do a good job setting up the context from it, or I almost got a little bit more relaxed and allowed this, and then it becomes the next time the person comes in, there's almost this like expectation, oh, I have this long now,
Yeah.
So there is some things that go on related to, I think sometimes if I don't like saying this word, but I'm going to use it, just like, my mind says, like, if I get lazy in a visit, it's going to go longer. And then, unfortunately, that increases the probability that person does come back, that the expectation is that's what they're used to. I don't know. I'm interested where your mind goes, because I really am hesitant to say that this type, I've had patients that had, really, really bad trauma and really, really difficult life circumstances, but still the visit went 20 minutes, 21 minutes. I've had people that might have been referred for something that we would deem as like less complex, or something like smoking cessation, and those visits have gone longer, just because something in the context came up. So I don't know. I would just say that my mind's like unsure. What does your mind say?
That's so interesting.
Yeah.
This is wild. No, I feel like a huge spreadsheet in my head of all the different scenarios. I feel like a younger person, so like a young adult, maybe teenager, who's coming in for the very first time, I find myself doing 35, 40-minute visits because of just the amount of context and a lot of expectations on their part of what is or isn't going to happen. And, they kind of will think it's like traditional therapy. So in some cases, they might actually be pushing it for it to be long. Now, these are gross generalizations, so it's not always. But I just find that we have a lot to tackle, and I want to make sure we get a really good plan and some psychoeducation, and that I'm very, very clear, because this might, this is like their first interaction with a mental health person. Yeah. So it's like that rapport, and that kind of goes for on the older individual end too, 60 plus, 55 plus, 50 plus, and they haven't ever met with a mental health person before, a BHC, but in their whole life, right?
Yeah.
And so sometimes I'll go a little heavy on the rapport, the clarity, clear plan, just to make sure that they have a really good experience. So I find that they can go a smidge longer. Ones that tend to go a little bit more predictable are folks who've been with me for a long time. They've worked with me for a long time, and I know that on days that I tend to be a little bit busier, I will give them a heads up and say, hey, we might be a little bit more focused today. We got a lot of patients coming in. So if you notice that it's a little bit closer to, 23, 24, 25 minutes, that's where he's talking about two sides of our mouth. We said we don't talk about time, but now we say we are. Because most of the time, if everything is calm, for some folks, we can tend to get into a rhythm of that 28 to 32 minutes.
Yeah, I think the people that come back, whatever we use the words that, they follow up more regularly or whatever, there is a rhythm that you can almost pick up kind of naturally that we as BHCs get into, them as patients get into. And I like that you said, like, sometimes it's good to kind of jar us out of that rhythm because there might be more, we're just doing this because it's the pattern now, not because moments are happening.
No, that was like super well said. And then there's all the scenarios that involve when a clinic starts to get busy, when you're trying to get warm handoffs.
Yes.
And so you have to be, whatever the opposite of lazy, very, very focused when you're having a lot of visits coming in. So, for us, that's like a Tuesday, Thursday, where we tend to have a lot of providers, and there's a ton of warm handoffs. So I know that my visits are going to have to be laser focused. So I might set them up and say, we got a lot going on today, but I think we can get a solid 10 to 15 minutes in for me to get to know you and for us to walk away with a plan. So I'm still engendering, and we've done other corners on that where we talk about like, oh my gosh, we only have 10 minutes together. So, we'll see what we can get done, but you're going to have to
undersell it completely.
But you're going to have to reschedule. Whereas when I get that in a really busy clinic, I say, we got a lot going on today, and we got 10, maybe even 15 minutes to like ask some questions, get to know you, and get something done today.
It's such an interesting reframe, right? Like if we are in a position, and that is one that I had marked down that I wanted to explore at times because I
what do you think on it?
Yeah, I think I still, I just don't talk about time a lot with patients. And again, like I said, like my mind just doesn't really go into these like, I
definitely talk about time more than you do.
I know, that's interesting. I want to reflect on that a little bit more.
But you're very functional, so.
And that's the thing. If it's serving the function that
you get more handoffs and see more patients than any BHC I know. So
I think the thing that does come up is that moment. And I might at times overtly articulate it. I'm definitely articulating to myself in those moments. Like if I'm in a busy clinic and there's multiple handoffs coming through, I am absolutely, I love the stance. Honestly, I should probably take this stance always. It just can be taxing at times. It's like I'm laser focused. I'm very, very intentional on making sure it's like I know there's other handoffs out here. I know other things are going to, and I'm not letting anybody leave. No one's leaving without. And I think that's a big point for us to pause on. And we've talked about this in other corners where a lot of times I think this can get phrased as, oh, you're not caring about the human sitting across from you. Or, when I talk to some BHCs, particularly trainees at the beginning, would be like, hey, we're missing handoffs. Like we want to, and they're like, well, I'm not going to cut short a visit with this person. And what's really interesting about saying that is like, so if we want to play that out, if you're saying you don't want to cut short this person that's sitting across from you, you're totally okay with someone else just going without care completely.
So if you were in there for 20, 25 minutes, they've already got 20, 25 moments with you.
Correct.
But this person gets no one.
This person gets no one.
And we're okay with that.
And we talked about this earlier. We also mentioned, and this might be an unpopular opinion, but this is why we're here, and to make people kind of have this thoughts that go up. The other thing that comes up within that, we're also missing out on someone that in that moment said they wanted help.
Yeah.
So not only is the person going without, this is where I don't want to say this because I don't want to be dramatic, but I'm not saying it is harmful to allow that person to leave. But if someone comes in and they say they need help and they're open to it and then we don't see them, I don't know. I think it decreases the probability of them being open to future help. So I think that might be harmful to not be able to see that person to give them care in that moment. So that's where I do think there's a sense of us needing to recognize that, I'm always thinking about the person sitting across from me. Of course, I'm giving them or striving to give them good health care. I am also thinking about the people that are not in that room that I want to make sure also get access to that.
And you've said this so well. Jeff has said this so well. I care just as much about the patients that I don't see as the ones that I do, as well as the ones that I might see as the ones that I am seeing.
Yes.
And that's a difference, that's another shift with the population-based mindset. It's very different than what we were taught. And I found that being transparent and honest goes way further than what I realized or I would have given credit to as a new BHC. And it's hard as a new BHC. Once you've been here for a hot second, you feel that you can explore a little bit more, test the waters a little bit more. I straight up might say to a scheduled patient, like, they followed up with me. I straight up might say like, hey, I have I'm getting paged for another visit. I feel really, maybe I'm just going to make up a time. Maybe we're 18 to 20 minutes and we have a pretty good plan that we're crafting. I might say like, hey, I'm getting a page. Is it cool if we focus on wrapping up this game plan? And then, we can definitely like follow up. We've been doing this once a month thing. It's been going pretty well. Is that what, like, I let them know what the scenarios are, or even on the warm handoffs, I let them know like, hey, we have this pocket of time. I have found that patients are so like.
I was going to ask, what's the responses, right?
Well, the ones that I've been working with for a hot second, we've been in the same clinic for 10 years now. They're like, Dr. Beachy, don't you worry about it. I remember the time that, you took extra time with me. Or, I know you're a busy doctor. I know you got a lot of other patients to help other than me. And I would say, listen, I appreciate that. And they're like, no, seriously, like it gives them an opportunity to help me. And that reciprocity, it's so beautiful in those moments. And I legitimately say, I'm like, you have no idea how much it means to me that you're giving me permission to go help this other person, and the smile that happens on their face. So yeah, you involve the patient into that experience, and
that has been my experience as well. The patients are so gracious.
That's the word I was looking for.
And it's even more than that. There's almost a sense, and I've never asked anybody this, but what my mind predicts that based on the response is like, in a very interesting way, like they know they're helping someone else. Like they know as a patient that it's like, hey, that's Dr. Beachy's going to go help someone else right now.
I've had them verbalize that to me.
Yeah, have you?
Oh yeah,
I've
had not uncommon folks verbalize, hey, I know there's other people who need help.
Definitely when I'm running late, people will do that regularly of just saying, I know you're helping other people, like because I was delayed to getting to them. It's interesting. I might start asking people, like if I do have to wrap up the visit, like it's like, hey, we're getting a lot of handoffs right now. Can we be intentional and wrap this up? And just ask them because I do get the same sense when I have to be intentional when doing that they know they're helping someone else indirectly. And the other thing that I really want to go back to something that you said, and I think that our one fellow, Shanice Santaolivia, she does this really well, and she talks about this, about talking up the time that you have with this person.
Yes.
We are going to, even if it is only 15 minutes, even if you know it's going to be pressed for time, it's like, we're going to get to work, we're going to come up with a good game plan. We're not underselling it, we're not underscoring it. The last thing that my mind goes with this corner, it's interesting because I think also within, like there's so many different narratives that get built up around these things that it's like, it's prescriptive, that it has to be 30 minutes. Obviously, we're not fans of that. There's also a sense at times it's like always having less than 20-minute visits or always having less than 30-minute visits, like that's a good thing. I don't know if that is a good thing. And I think that's the thing that, we've had to have these conversations sometime with trainees. It's like, hey, no, I think you might need to give that person a little bit more time to have a moment. I remember Kirk telling us this, right? That it's like, hey, if you take 10 extra minutes, and so instead of your visit being 25 minutes, it's 35 minutes, maybe that person doesn't have to come back in a couple weeks. Maybe we hit a moment that it's like radical change happened. So he
was the first one to say that brief, to really explain, isn't just about the duration of the visit.
Yes.
It's about exactly the point that you just made. If our plan gets tightened up to the point where instead of having them come back in 1 week or 2 weeks because the plan was so not good.
Right.
Not good.
Yeah.
that they're able to push it out 4 to 6 weeks or 3 to 4 weeks or even 2 to 4 weeks. That's part of the brief process too. Sorry, go ahead.
No, that's exactly it. That I would also say this is where all of these things can be true and then everything cannot be true.
I know.
It's based on what you said at the end or at the beginning. What is the end goal that we're trying to have within PCBH? To us, it is reaching we'll say our value, providing contextual and compassionate care to the vast majority of our population in the moment that's requested. So that means we have a lot of visits. We're giving good patient engagement and contextual and compassionate care. We're providing care when it's needed, accessible via handoffs, and we're seeing a lot of unique patients. If you're getting there, then really how long you're taking in a visit, I really don't care about. Both ends though, that if it's always every single visit's under 20 minutes, I don't think you're probably giving the best patient engagement, the best contextual and compassionate care. Then if all of your visits are over 45 minutes, probably a little likelihood that you're actually seeing people, a large group of people providing care in the moment. That's the thing. It's not a matter of what the visit length is. Even though we will say it should be between 20 to 30 minutes, 28, 30 minutes seems to be the sweet spot. That's the thing that we will say. And though, it's about where we get to and the end thing there. Where's your mind going to finish up?
I was thinking of our metrics video. So we've done tons of videos on metrics. I don't know if they're all on YouTube, but we have our other training, our PCBH courses.
Oh, yeah.
And when you look at the metrics that we track, it's visits per clinic, warm handoffs per clinic, and unique patients. Those are the only 3 that we track for I guess it would be for the BHC. And then we track patient satisfaction, employee engagement. And there's one more.
PCP satisfaction.
And PCP satisfaction.
Yeah.
But if you think about it, we're tracking visits per, warm handoff per, unique patients. You might say to Dave and Bridge, again, that's crazy. That you guys, you're doing, your corner is called PCBH corner. And you're not tracking visit length. It's not that we're not tracking. I mean, it's in the electronic health record. Dave has run some reports. That's where we got that I think it was 75% were between the 37 and under minutes. I had run it on myself. Mine was actually a little bit lower than the teams. I have some theories on it. That's for another day. But I think it has to do with you being here so long and having, a little bit more regular. So we're not saying not to track it because it's important to, if you're having but see, it's all in the service.
And it's not an outcome measure. It's a process measure. It's not,
right.
It's not a primary, I would say it's probably, honestly, at the best, it's a tertiary kind of outcome or process measure. It's something that would maybe be a cool thing to run a report on, not something that's a program defining thing to run a report on.
And I think that the only time that you'd really get super curious with that is if you were missing handoffs or your productivity was low. Because in those scenarios, then you kind of start drilling in, and this absolutely could be an area
well said.
Of that you're too meandering, you may be going down rabbit trails. And so, yeah, I mean...
And this would be on the opposite end too. Like if you're looking at your patient engagement scores and people are like, man, I don't feel like I'm being seen. I don't feel like I'm being heard. I'm not really engaged with this. And then we look at the data and every single one of your visits is under 20 minutes. It might be like, hey, are we giving good care? Like, are you giving good contextual, compassionate care? And not saying that means over 20 minutes. We're just saying like, if you're indiscriminately holding tight to anything, rigidly to anything, that's where we're going to get in trouble.
So our only North Star, our North Star, once again, is gather.
It really is. There's such a parsimony to that. All these questions that get asked about PCBH. What do you do in this? What is this? Is that right? Is this the right number of visits? Is this the right visit length? Am I doing the right thing? It's like...
That's why we started doing these PCBH corners, is to take these topics on. Because when you're new, nothing makes sense when you're new, in my opinion. I remember Kirk telling us the visit takes as long as the visits take. And I remember my brain absolutely exploding because I was like, I don't know what that, I know what you just said was profound because I can feel it.
Yeah.
But I have no idea what the hell you mean. How is the visit going to take as long as the visit takes? What if the visit takes 2 hours? Are you just going to say it's 2 hours? Are we back in like Freudian,
right.
psychoanalytic days? Like that doesn't, and now being 10 years in from that experience, I'm like, oh, the visit takes as long as the visit takes.
And we say that now. And again, going back to...
But I now know what it means.
If you have I'm not saying a 2-hour visit is right or wrong. I'm just saying, placed in the context of PCBH, where, as you said, the goal is to see as many people as we can, get out to a unique patient, and provide care that's on demand and accessible. 2-hour visit just might not have a high probability of achieving those values and the goals. The last thing that I would also end on, we should probably just stop talking about time as much as we do. A lot of ways. Allow moments to define it. Allow these different things to kind of come up with, like, this is where, I don't know, again, it's descriptive. It's not prescriptive. It's the goals and the values that matter the most. So I don't know.
Those core principles are going to help directors and new BHCs if you don't have a lot of supervision going on. When you start asking yourself, what should I do in this scenario? What should I do in that scenario? When you're rule following, stuff breaks down, and it breaks down quickly because it's like, so you're saying that 24-minute visit I had was inadequate,
right?
And you're telling me that like it's just so confusing. Then the 45-minute visit was wrong. Each visit was wrong, and it's like, well, then the rules break down, but core principles.
Well said.
When you understand the theory, what you're aiming for, suddenly you have a way better litmus test in your head of like, I'm on minute 24. We have a really good plan in sight. It's a 1 degree change. Patient feels good about it. I feel good about it. There's handoffs that are coming through. Now you know that you're not done because it's 24 minutes.
You're not?
You're done because you got a good plan and there's handoffs coming through. So you're following core principles of gather. So you're being accessible and you're being highly productive.
And that's the thing. Success isn't how many minutes are in the visit. It was if a moment happens, if this is a good plan, if we feel good about it. That could be 24, that could be 7, that could be 45, that could be 52. That is the moment. You know what they should change? We should all change. As much as I love gather, the R, how it's routine? Yeah. How awesome would it be if we changed it to reach? Oh, I know. I guess maybe within the high productivity they would say reach is maybe in there. But that's just that's just having a lot of visits. Anyways, that's for another day. We should end. Another day. Maybe the next PCBH quarter. But as always, let us know where people's minds are going, thoughts, questions, conversations. I really enjoyed this. And this is a video that we've kind of circled around and talked about it different ways, but never made a video about it. So I'm actually really glad that we finally answered it, this is my opinion. In my opinion, the vast majority of visits should be 30 minutes, give or take, all the way down. That's what our data shows. The normal curve. Yeah, and well said. And all the way down the normal curve. It's descriptive, not prescriptive. Thanks for stopping by.